those that are approaching death and the final phase of life, if you will, without defining what that is. At the same point in time, we're interested in things that can and should be done at different points in time, maybe much earlier in life, including pulsed or whatever, that would be relevant for individuals that are in that final phase of life who may be approaching death. Question, looking forward, now that we have the Affordable Care Act, which is designed to try to provide universal access, may or may not, but is designed to do that, which will require electronic medical records, all right? Now that, as Alan said, we have to come to the realization there's a finite amount of money and we're spending other people's money here. What are the opportunities, you know, to try to think about a process, you know, that could be applied on a prospective basis using electronic medical records, either for certain types of individuals or certain states of life or certain stages of life or when they're applying for eligibility for certain things, where we might be able to take some of these concepts and build them into a new system that would be implemented prospectively. That's the first question. And the second question is, we've got 51 jurisdictions dealing with a lot of these issues. And is there a need? I realize there's a huge challenge. Is there a need to try to think about legislating or doing some things that would have national application, you know, dealing with, you know, liability and related matters?
Well, I'll say something about the second one first. Thank you. The one thing I talked about uniform state law. One thing I didn't talk about was, of course, federal law. The federal government really doesn't have jurisdiction in these areas except to the extent that it might through the spending power, which is to say Medicare, probably Medicaid too, but it hasn't chosen to exercise that. Do you want to talk about political reality and what's possible, or you want to talk about what might be best?
No, I think we should talk about what is desirable rather than what is politically feasible, because otherwise we wouldn't create this committee. I mean, frankly, if we were concerned about being politically correct, this committee wouldn't exist.
Yeah. Well, if you go back and take a look at the PSDA, Patient Self-Determination Act, that was mentioned yesterday from 1990, there was a federal statute that had its basis in the spending power in Medicare. It applies to institutions and individual institutions and providers that accept Medicare, receive Medicare payments. I think it's had a tremendous impact. I don't think it's been, when I say tremendous, I mean widespread. I don't know how important it's been. Its impact probably has been more educational than anything else. It's taught healthcare professionals that there's such a thing as advanced directives. They ought to be looking at them. They ought to be thinking about them. They ought to be promoting them, that kind of thing. And I think it's useful to have that done uniformly and nationally. And I think that's a much better solution than state solutions to these kinds of problems, because then you get tremendous variation. It's more difficult to establish educational programs about them, best practices. But I do worry about one thing from lawmaking in general, and that's bureaucratization. That law making and law implementation especially leads to bureaucratization in the implementation process. The best intentions get bureaucratized, by which I mean things get reduced to forms. And then residents say, or attendings say to residents, get the patient consented, or get the code status. And there's so much missing behind those ideas. There's so much, it's such a rich area that you can't reduce it to that and not have a seriously flawed outcome. And I think this has been true with advanced directives, with informed consent in clinical practice, informed consent in research. I'm not the first one to say this. I know that, but I'm here, so I'm saying it here, so it's on the record.
I might go back and address the first question if I remember it.
So I think you were asking about different things we can do sort of in different stages of patients' sort of lives and disease trajectories and how we can use maybe the medical record, if I got that correctly. And I think we've been working with a model, and that's what our Prepare website is based on, that for people who are earlier in their disease process, or maybe they're still healthy, that instead of asking them whether or not they want CPR or mechanical ventilation, to spend that time, if we're calling that advanced care planning, to spend that time teaching people how to identify what is important in their life and how to make informed medical decisions based on that information. And I think Susan and I were talking the other night about, we talk about values and goals, but what does that mean? And I think patients don't know what a value means, but how do you actually identify what's important to you and then be able to translate that in a crisis situation into the care that you want? And that's a very tall order. And I don't think we spend time training patients to do that. So from my perspective, early on, instead of asking people about CPR and mechanical ventilation, it really is how can we sort of prepare you and your family and your surrogate decision makers to come to the table with doctors and to make these informed decisions. So I would say that that's number one. One of the other things to think about, I think, again, we keep coming back to respecting choices because I think it's a great model, and they have a first steps, next steps, last steps. And I think that there isn't going to be a one-size-sort-of-fits-all model, and I think we need to sort of be able to change based on person's needs and where they are in the disease trajectory. In terms of the EMR, I don't know if you remember that slide that I showed you, I think that there is a lot of promise if you could just figure out how to use these things correctly, where you could see, and I remember when I was talking to Bud from Respecting Choices, they were working on a similar model where if a pulmonologist writes a note, it gets in there, and then 2 years later a cardiologist writes a note, but then the primary writes a note, and you can go back and you can see the sort of trajectory. If somebody's health is changing or things happen in their life, you can read the story. And I think, I'm on the ethics committee at the VA in San Francisco, and I have to tell you, I'm sure we've all sort of been there, where we have a form or somebody's saying something and we're all wrestling, like, are we doing the right thing here? Is this what the person meant? And I think, again, it's getting back to figuring out how can we document somebody's voice? Is it sort of these ongoing goals of care documentation that we put in there? Is it video recording somebody, audio recording somebody? I don't know exactly what the answer is, but I think it's the form, because EMS needs the form. We need to know what to do in crisis situations, and adding in this other information at the same time.
Provide the
Hi, this is Naomi Karp on the committee. Yes, this is a question for Alan to begin with, and then also I just wanted to make a comment. You talked sort of indirectly when you were talking about the authority of surrogates to act on a pulse, to change a pulse, et cetera. And you referred to what I generally call default surrogate laws, that you called surrogacy laws, which is when someone doesn't have a proxy designated. And we've had those laws for a long time, but I'm not aware of any studies that really look at how those laws are being implemented in the field, how much are clinicians actually looking at who is the person in the hierarchy, and are they going to that person for actually making decisions when the patient is incapacitated. So I'm just wondering if you or anyone else on the panel is aware of any work going on in that regard, because I think we've all made ourselves feel better because there is a legally authorized surrogate somewhere, but I'm not sure how activated that is. So that's my question. Just wanted to share something. Charlie Sabatino shared with me a draft, but it's not public yet, of a Pulse legislative guide that Charlie and a couple of the other people you mentioned, Alan, have worked on. And it talks about sort of 12 key legislative issues in Pulse. It makes recommendations, but it also has analysis of the existing law, and they expect that paper to be out within the next couple of months, which will be before our committee has finished its work. So that's just really a heads up for our committee that we should look for that report, because it will supplement the great information that you three have given us today. So now I'll just flip back to the question and see if anyone has anything on that.
I can speak a little to that. Actually, Indiana does have a new post program that went into effect July 1st, and we do have a default surrogate statute in the state of Indiana, but it is actually unique because it does not specify a hierarchy. So we have a committee of people who can make decisions on your behalf. And one of my colleagues at Indiana University in the School of Medicine, Lexi Torkey, is working on this issue of surrogate decision makers for people who lack capacity in the hospital setting. Actually, the biggest challenge they have is finding anyone who's willing to assume the responsibility for making the decisions. And we've had a lot of debate about this lack of a hierarchy, because we end up with, in some instances, a whole committee of people, but at the same time, the person who may be most involved in care for that person on an ongoing basis may not be on the list. So, for example, grandchildren are not on that list. Nieces and nephews are not on that list. And so we've had a lot of discussion about what do people actually think is going to happen? Who do they think is going to make a decision? I have not found any research about that specific question. I think it's an interesting question about whether the hierarchies, there is a typical hierarchy in most states that start with spouse, whether that's really consistent with what people expect and understand and desire. And obviously there's always the opportunity to appoint a healthcare representative or healthcare power of attorney, but not everyone is aware of that, not everyone understands that. I think it's a real a problem that we have, that a lot of people seem completely, have never really thought about this idea, but someday they may not be able to speak for themselves. And I'll just tag on to some of Rebecca's comments in the response to the earlier question. I think one of the things we can also build into systems is encouraging that to be an active part of an admission to the hospital, is encouraging people to engage in conversations about who the appropriate surrogate would be for them if anything were to happen, because everyone could benefit from having that individual appointed.
Which is part of what the Patient Self-Determination Act was supposed to do.
Right, and it's too weak. It's the way it's enforced is so basic that I don't think it really motivates hospitals to do anything than have the admission clerk ask, and that's largely the model.
Well, and that's part of the problem, is who's doing the asking. It's an admission clerk. Do you want a private room? Do you want a TV in your room? Do you want Jell-O for dessert? Do you want a surrogate decision maker? So.
But there are systems where they do, the system in lacrosse where they do use respecting choices, they have very high rates of appointment of power of attorney for health care because it has been systematized. It's part of what they do. Everyone within the hospital at Gunderson, including the person at the information desk, knows what an advance directive is, has a copy available, and knows where to send them to talk with a facilitator. But that's a system that's embraced this is a central part of their mission, and they've invested the resources. Not every system is going to prioritize in that same way.
So can I just follow up on that for a second? What would it take to get the systems to do that, follow in that direction? Because in the absence of that, you just have the current chaos like this.
I think there need to be regulatory and financial incentives, and I'm not necessarily going to be able to speak to the specifics of what those should look like, but if Joint Commission was reviewing on the quality of the advanced care planning process within a hospital system, you can bet your bottom dollar that they would up their process, and you would see an actual systematic approach where they would have staff who were dedicated, that their whole job was to do advanced care planning facilitation. That's the way Gunderson structures it. They have an advanced care planning department. I don't know of other hospitals that have that kind of dedicated resource. So, I think there need to be regulatory incentives, and I think there also need to be financial incentives. We need to be, this issue of can you bill for those conversations? And I think it needs to not just be physicians. Physicians don't always want to engage in those conversations. They're not always comfortable with them. They're not always skilled at that. I think we need to think more broadly about who's capable of helping people reflect upon what their goals are. And I don't think that that always is a physician, particularly when we're talking about identifying a surrogate.
Let me mention one other thing real quick. The Affordable Care Act, in many ways, crossed the Rubicon on a new issue. And that is, for the first time, a significant way, it didn't use an incentive to say you should do this. It says you shall do this if you want to. It says you shall do this if you want to be reimbursed. In other words, if you want to be reimbursed by Medicare, if you want to be reimbursed as part of these exchanges, then you must do certain things. And I'm not saying that's always the preferable way to do it, but to the extent that you've got a payer that dominates the market and is likely to dominate the market to an increasing extent, that, again, is a new opportunity. There are pros and cons of that. I appreciate your concern about bureaucratization, very much so. But that's something that they've shown that they may be willing to do in appropriate circumstances that at least we need to think about. I apologize.
Yeah, no.
Could I just revert to Naomi's question before we lose that thread? On studies on default, the use of default surrogates. I had a research assistant just in the past week or two try to find some information on this, couldn't find anything. And I asked him to search the medical as well as the legal literature on this. And so I think this is a fertile area for some exploration. However, I would also say that my anecdotal experience is that even before these statutes existed, it was the common practice of physicians to turn to family members when patients couldn't make decisions. And that all the statutes did, the surrogate decision-making statutes did, was essentially to codify accepted medical practice, which I think was the law beforehand, if anybody had asked me, and I certainly would have defended it in a suit against a surrogate who made a decision, and the claim was they didn't have authority. So well, it's an interesting question. I'm not sure how critical it is. I don't think people are going around saying, geez, we don't. It's critical in the case of patients who don't have family. Yeah, that's where it's critical. But when there's family around, I'm going to ask the doctors, don't these decisions get made?
Not always well.
Well, yeah,
You know,
not always well, but.
Yeah, there are strong differences. Yeah. So I just want to stay on this theme for a moment of sort of case models, right? So if you described an institution that is doing it presumably correctly, what can we learn from that in terms of the generalizations that go on to other institutions? Because to the point that you made, Rebecca, I mean, I agree with you that Epic is going to be likely, for better or worse, the EMR in most institutions in this country, at least for the current future. And it is possible many institutions are putting into the Epic headliner whether or not there is an advanced directive or a pollster or whatever. But you know, that begins with someone sitting down and having the discussion and then updating it and being comfortable with that and making sure that. So there must have been a reason why at Gunderson there was a decision made. This is important. Let's do it. Do we know anything more about that, and what can we learn from that?
Yeah, leadership. Yeah, I mean, I think I think it's unfortunate that I think Bud Hammis would be obviously the very best person to talk about this. But there are multiple factors, including just the reality that La Crosse County, Wisconsin, is a fairly small community where people know each other and have work well together. Historically, the Gunderson Health Clinic, I don't know a lot about the history, but I know the way they began. There was quite a bit of collaboration. It was physician run. There was a lot of collaboration and good communication historically that Respecting Choices was able to build upon. And I think it does offer a nice case study for an organization that has done implementation successfully. Other states have contracted with Respecting Choices and are using this model, but it is involved. It is expensive. We are using it in a CMS innovation grant that I'm part of. It's not for the faint-hearted. It's a big undertaking to try and implement systematic advanced care planning. and requires a lot of time and effort in terms of training people to ensure that they have the skills. And so I think that there are some, when you think about why isn't this happening everywhere, there are lots of reasons it's not happening. I do think that Gunderson is sort of a unique environment in which this idea was really able to take hold, and under the leadership of Bud Hammis, they were really able to make this something pretty impressive. I just don't know ultimately if you could get every system in the country to look like Gunderson, because there are some unique features to it.
Just say a word about that. I don't know anything about Gunderson, but just listening to what Susan says about it, it doesn't sound like any health system I know where the even not-for-profit health systems, where the most important thing ultimately is how much can we save so we can pay the executives more. And I don't think.
Could you repeat that again?
I'm increasingly sorry that I said it once, or I will be. But I don't think that that kind of thing is going to happen unless it's mandated.
Thank you very much. I now know why, Professor Meisel, you were one of my sister's favorite professors in law school at Pitt. So I'd like to see if I could push Rebecca and Susan a little bit about thinking about this model of advanced care planning. I think we've gone down this pathway trying to build the perfect mousetrap, which was the perfect form. And some observations. The certainty of patients' preferences change over time. So it's really dependent on the disease trajectory. Second, we're not all white middle-class lawyers. So that, I have to have a variety of tools that come out to deal with the university dean who I've taken care of, to the, housekeeper whose predominant language is Portuguese in my community. So I really would like to push you on thinking about how we should really think about this advanced care planning intervention, how we vary it over time, and how do we think about what really are tools that we, I think, have put too much in the forefront and focused on a piece of paper and not focused on this really complex, messy communication process. And I will give up the mic immediately.
Well, I will say at the outset that I haven't figured out my entire career yet, that would be, if I could figure this out, I'd be done. But I would say a couple of things. So I think that it's not going to be a one-size-fits-all model. It just cannot be. As I was saying in my slides, our country is incredibly diverse, and people are going to want different things. So I often say, for myself, I probably would use the conversation project questions because they're at a higher literacy level, and I understand the information, but my elderly patient who has a 5th grade reading level isn't going to be able to use the conversation project. They probably might use my website. That might be better for them. So I think that's sort of one thing. But I also think that it is very naive to think that you can do one thing and have it work. And I think we've done one thing in the forms. That doesn't work. Then we are doing okay, let's teach only doctors, how to have these conversations. That doesn't work. And I think, in terms of thinking about prepare, I think one of the reasons that I really wanted to start focusing on patients is I felt that when you look at the piece of the puzzle, we have policy, we have the hospital reimbursement system, we have doctors, we have nurses, we have EMR documentation, and then you have patients. And I feel like that was sort of a piece that was sort of being left out of the puzzle. And I will say a lot of these things come from me taking care of my patients, but I will tell you that a lot of these things come from me taking care of my own family members who literally had no leg to stand on when they were facing cancer treatments, surgery, and things like that. And so it's sort of like I feel like we have to sort of come at it at all levels. But I will say, and maybe this is naive, and we talked about this a little bit at the CTAC meeting, Bill, but I sort of feel like the tide is changing a little bit. And you see, even with the issues related to not paying for sort of inappropriate readmissions, that in and of itself has changed a huge amount of what's going on in hospitals. And I honestly do think that, in terms of public opinion, there were all of these things about death panels and things like that, but I really think that people are having these conversations more, and so again, maybe I'm naive, but I'm hoping that it'll all come together. The one thing I will also say, and I think what I really appreciate about CTAC, is that we talk about hospitals and all these things. We also need a public, media campaign. I know CAPC is working on that as well. We have to engage the public, and we have to engage the media.
And I will just add, I do agree, POLST is a tool. It is not a panacea. It is a tool for clinicians to communicate with each other. And I do think that, a lot of my work is focused on, does it actually work? Are they able to communicate effectively? And I think there are unanswered questions about what goes into that documentation, what goes into the development of it. I fully anticipate there's a wide variation in the quality of the conversations, and that we are going to see some disturbing practices anecdotally. I know of disturbing practices of people being handed forms and being asked to fill them out and bring them back. It's totally inappropriate. It's a tool that's written for clinicians, by clinicians, in clinicians' language, and patients and families shouldn't be filling it out like it's an order form in a grocery store or something. I mean, it doesn't make any sense. And I'm concerned about that. I think some of that reflects the lack of knowledge of healthcare professionals, and we have a huge uphill battle, and we have to remember that as much as we struggle with patients and families understanding why we're asking these questions and encouraging them to engage in these conversations, a lot of healthcare professionals share those same views. They don't understand what the point is. They don't think it's a priority, and they get that message from regulatory incentives. They get that message from the way their hospital or their system structures incentives within the organization. So, I do think that when we think about changing that, we need to be attentive to both the healthcare professionals who may not understand the value or see the value, as well as patients and families. One of the things I do like about POLST as a tool is that it is different from advanced directives because it can be changed, and this is one of the things that I think a lot of people don't understand. They think that, once you've written it down, you've committed to it forever, and I think, unfortunately, that's one of the legacies of advanced directives, is that we've sort of given people this message: you get one choice, you got to get it right the first time, because then this is what we're going to do, and there's no deviation from that. And I know in passing legislation in Indiana, I had multiple conversations with people who were convinced that, this should be carved in stone, and once the patient says they want limited additional interventions, you should never reevaluate that. And I think there's a lot of danger that it gets interpreted that way, truthfully. But I also know from our research that a good number of forms are reviewed and revisited. In the R01, 26% of people near the end of life had their forms either newly issued or revised in that last 2-month period of life. So, I do think that in communities, at least where people have more experience with it, they understand that this is a modifiable tool that needs to be adapted. But again, what goes into it ahead of time, I do not know. It's really encapsulating whatever is the existing practice. It doesn't teach people how to have those conversations.
If I might. We keep talking about healthcare professionals, I do too, but I think it's important to understand that POLST is often implemented by non-healthcare, non-professionals, by which I mean personal experience. I learned more of this from personal experience. I think my mother-in-law lives in an assisted living facility, and the people who run it are not healthcare professionals. And they are the ones that say, you got to have this form filled out. My wife brings it home and says, what's this? Do we have to have this filled out? So, it goes down to the lowest level here. And if you want to talk about educational strategies, it gets even more complicated than healthcare professionals.
This has been really terrific. Three really helpful sets of insights. So we've been talking about informed decision-making. We've been talking about patients really understanding what it is they're trying to do, the ability of patients and their surrogates to make decisions that are consistent with their values, and so on and so forth. So what is the state of play in the United States, in your views? I mean, is there any research indicating whether we're at a 5 on a 10-point scale, whether we're at a 6, You're talking about assisted living facilities, health systems, nursing homes, et cetera, Where do we stand as a nation in achieving the level that you're all advocating for?
Well, I'll say something. It won't be too helpful, but I would answer the question with a question, and that is compared to what? If it's compared to 30 years ago, I think we've made tremendous progress. If it's compared to where we ought to be, I'm going to turn that over to my two co-panelists.
Thanks a lot, Alan. I think we have a long way to go. I will just say, again, from what I know from, and not every population, I work with a lot of disenfranchised populations, but that takes up a lot of our U.S. population, and I would say that there is a lot of misunderstanding and a lot of disempowerment. And I think even just in, starting a hypertension medication, I think patients don't even understand what's going on with that, much less what's going on with end-of-life discussions. So I personally think that we have a long way to go from the patient perspective.
And I'll just take a stab and say I think it's highly variable. This kind of and depends on where you're talking about and what you're focusing on. And I also think that one of the challenges we have is that we don't have a lot of great information to evaluate that question. I mean, we often turn to, the use in the Medicare population using the Dartmouth Atlas data, which has, limitations. There's lots of variables that you can't take into account. We don't have good ways to assess what you're asking. And I think that's a real challenge because it will be really hard to measure progress without some objective indicators that tell us, where are we at now and how do we know where we're going. So that's a researcher's answer, by the way. But
I also think that what we're doing here is making successive approximations towards getting where we want to be, and where we want to be is a moving target. So there's never going to be a good answer to that. Part of the problem here is we're dealing with issues which are horrendously complex. Forget the end-of-life stuff. Just medical decision-making, making decisions about what the simple old informed consent stuff is very, very difficult as soon as you get into any level of medical complexity, and these days almost everything involves complexity. And you're talking about educating people about these things to make decisions, most of whom have never thought about them, many of whom don't have the intellectual capacity to think very deeply and hard about them, many of whom are cognitively limited, and the problems just mount up. So we continue to do a little better, but the target continues to move.
So I don't want to challenge the concept of advanced care planning or patient self-determination because I think they're really important components of the direction we need to go in. But one of the things Bud Hammis talks about a lot, which I think is one of the reasons for the failure of advanced care planning as the solution to bad care at the end of life, is that it doesn't matter if you know what people want if you can't honor it. And we have a system where it really is almost irrelevant what your wishes are because the default is acute care, the emergency room, and the hospital. So if I had a post form and my loved one was on the floor gasping for breath, and the option is leave him there gasping for breath or go to the ER and get intubated with relief because there is no palliative care at home, because there is no one I can call who will help me know what to do in the acute situation when someone's gasping for breath or in pain, you're damn right I'm going to say, take him to the ER, take him to the hospital, forget the post, I'll hide the post, I'll bury it in the garden. But it's almost, in a sense, offensive to ask people what they want and then not bother to do anything that's going to make it possible for them to have a well-supported, safe, and protected experience during these very vulnerable periods of time. And some of you may have read in The Guardian last week or the week before about what happened with the Liverpool care pathway in England, which was a countrywide and actually UK-wide effort to systematize and standardize care for people who were dying. And just as was described with the Post, it was distributed everywhere with financial incentives to use it, without adequate training, without adequate quality standards. So people who knew nothing about palliative care were telling family members not to give sips of water to dying people because you're not supposed to give hydration to dying people. A great deal of suffering occurred, and they've eliminated the Liverpool care pathway in England. You know, so something that took a decade to develop, was piloted at enormous expense, has now had to be abandoned because the ability to honor those wishes in a real way never happened, and there was never any training for the process, the conversation process that Rebecca is talking about, that Bud is trying to implement. So I kind of feel like we just keep hammering away at the same almost irrelevant problem and are not paying attention to what the default healthcare system does, and that's what we need to change. Then patients' wishes will have some salience and some ability to influence what actually happens. But by itself, it's like pissing in the wind. And so I'd like to hear
Do you want to comment
Yeah,
on
I mean, all I can say is I wholeheartedly agree with everything that you just said. And I think, you know, and maybe this is a task for this committee because you do have a chance to sort of talk about all these things. And I'll just go back to the point that if we keep focusing on one thing, we are going to stumble every time. And you think about the Liverpool pathway, they had a couple pieces right, but they didn't have all the pieces right, and it's not going to work. And so I think if you guys can delineate what all of those different pieces are, maybe we'll get somewhere. No?
Thank you for a wonderful presentation, Jean Kuttner from the committee. And we've talked sort of around it, but I wonder if we could push the committee to talk about what would you see as the right quality measures around advanced care planning?
I'm going to let you take the first step.
Oh, great. Well, that's a great question, and I have been suggesting that we need to do a better job of providing incentives, and that would include quality measures. You know, I think one of the things that the experience with the MDS 2.0 version, which was the nursing home minimum data set, is that just having people check a box about whether there was a DNR order or a DNH order for do not hospitalize or a mark that there was an advance directive was not adequate to motivate people, and in fact the quality of that data was pretty poor. So, you know, I think it is going to have to be more comprehensive than just, you know, a process that allows people to say, yes, it's done, like we asked them at admission, whether or not they had an advance directive. So I do think some of the quality indicators include education for the healthcare team about conversations about end-of-life care. There could be quality indicators focused around community-based education, although, you know, I think ideally there would be some focus to that. The earlier question came up about what happens with electronic medical records. Can you identify people who are more appropriate? Are there group medical appointments where people have conversations about what are the likely complications of this condition? And, you know, what can you sort of expect, and how does that fit in with you? Can we have some more purposeful conversations and have those be part of the expectation? I think also quality indicators around education. I think there's still very minimal education in a lot of healthcare professionals training. I'm more familiar with nursing, and I know it's pretty variable in terms of the amount of information that nurses even hear about in their undergraduate programs, alone once they get out into practice. You know, so I think there can be some educational modifications, and that would require accreditation organizations to have to modify and cram more into their already packed curriculums. But I think that's a great question. I think it's something I would love to have the committee also ponder, because I obviously don't have all the answers, but or even close to all of them. But I think we need. I do think that having some kind of benchmarks for organizations, for institutions, are going to help drive practice. But they need to be thoughtful. They can't just be, did you do it, yes or no? It needs to be about what process is in place. Do you have specially trained people? What FTE do you have dedicated to this? I think some of those questions need to be posed.
I think, and these are some of the things that we wrestle with in our studies. And so again, in terms of measuring some of these things, so I don't know if this will help, Jean, and you can stop me if it's not. But I think when we think about what is successful advanced care planning, we always come back to the fact, do you have a PULSE or advanced directive documented in the medical record? And I think in terms of what is successful advanced care planning, as we were talking about, there is no one-size-fits-all model. And I think we need to sort of broaden the scope of that. So for one family, it might just be that it's documented somewhere in the medical record that they've been talking to the family for the last 20 years. They don't trust you as a doctor, but they've got it figured out for their family. That, for them, may be successful advanced care planning. So I just think that we need to think about it more broadly in terms of when we say something is successful. Some of the other things, we talked a little bit about this issue about decisional regret and decisional conflict. What is a good decision? The VA, so a couple things I'll say. First of all, I'll go back to the Canadian study I was telling you about. So somehow, we talk about people's choices and values change maybe right up to the end of life. Somehow, this research group was able to go into the hospital in the ICU and ask people and their family at that moment what their goals of care were. And I think that's one of the first studies that I've actually seen. It wasn't an advanced directive from 2 weeks ago or 5 years ago. It was, what do you want right now? And then did you get the care sort of that you wanted? And I think in terms of when we think about some of these quality measures, why can't we sort of wrap that into what we're doing? And I keep thinking about how I always say it wrong. It's like CAPS or CHAPS or whatever it is about what is it? Age caps, thank you. A lot of hospitals are using this. It's standard. I know even at our county hospital, they're asking outpatients this in the outpatient setting. Why don't we have something that's sort of similar for end-of-life care? And then going back to the VA has these after-death surveys where they try to ask, decedents' family members, and I can't remember if it's 3 or 6 months afterwards, but at least there's some attempt to ask about satisfaction, communication, and things like that. And I think, I don't know, it might be something to think about in terms of measuring quality there. I think I'll stop there. Anything on your end, Alan?
No.
Okay.
Just to recall, ACA required that there is a hospice version of HCAPS. It is in the field. It's already been published in the Federal Registry.
Great.
We'll make in April.
You said it's for hospice?
For hospice only. Okay. It will be implemented in 2015, first quarter 2015. So there will be an instrument that's currently in the field, been validated and tested and implemented for hospice by 2015.
First, I want to thank all three of you for really informative, interesting, helpful discussions. And Alan, I hope we're still friends. I guess it depends on whether you get to the airport in Houston, which is the last part of your sort of odyssey today. I heard very clearly from the three of you in different ways that advanced care planning documentation, such as PULSE, is a good thing, and it has beneficial effects. But in addition to that, we really need conversations which have to be skilled, repeated over time, et cetera, and documented as well. But that these are hard to do. It's hard. So I want to ask you sort of the question that relates back to some of the resource issues, Alan, you first raised and we're struggling with. How many person hours, leaving aside the startup cost, the training, the education, how many person hours per patient does it take to get the basic advanced care planning PULSE completed? not just check off the box, thank you, and now do you need a parking space? How many person hours does it take for that basic Chevy Volt version? And then let's think about the Cadillac Escalade. Or how much does it cost to really do it the way, Rebecca, you were talking about, in terms of having the check back, seeing if what they really understood, bringing the family into discussion? Can you give us a sense of what that involves? Because ultimately, on your question is, what's the value in all these interventions we do? And there are things we kind of hope that Pulse will maybe save some money because people will not have care that they don't really want. But there are also things we need to do because it's good medicine and better patient care. But can you help us quantify what we're talking about?
So again, it depends. So I would say the low rent version.
Basic version.
The basic version, and not the desirable version. It could take 2 minutes. I mean, I mean, I'm.
Yeah, but not the cut rate.
Yeah.
Not the Yugo version.
Not the Yugo. Okay. No, I mean, I
It's a decent minimum care.
I think, I don't, first of all, I don't know any data about this. Okay, so you're really asking for a guess, and,
Anybody have data?
and not to my knowledge, there's no data. I do know, I think of Respecting Choices as the Cadillac version, and, the Last Steps piece uses a structured interview guide to engage in a conversation about goals, about prior experiences, about preferences on Pulse, and that easily takes about an hour for the facilitator to have that conversation using the structured interview guide and prompts. But then if there are questions for the physician, those would go back to the physician. That would require intervention by the physician to talk with the patient further about the complications or the disease process, questions about the treatments and how those interrelate. So I would say easily 3 hours.
Well, I was going to say another one of the reasons that we sort of decided to create an intervention for patients and thinking about patients at a county facility that don't have 3 hours and don't have resources, or what are some of the things like the Conversation Project or like the Prepare website that patients can do a little bit of their own homework and come to those into those interactions a little bit more informed, and maybe it doesn't take 3 hours. So I think when you were talking about the 2 minutes, I've had 2-minute conversations with patients because they're like, yeah, we've been dealing with this for 20 years. I already filled out these forms 5 times. Let's just do it. And they know exactly what they want. So I think if you can do maybe a little bit of preparation of the patient ahead of time, you could maybe decrease some of that time with the clinician.
I want to pitch an idea I've been trying to push for about, my whole career. And that is that to a large extent, we're asking people to do a task that they haven't been trained to do, don't want to do, don't have any interest in doing, don't think is important, takes their time and wastes it in their view. Why don't we create a new profession of what I've called, but you could call it other things, I suppose, health educators? People who want to do this, know how to do it, like doing it, and we might get much better results more efficiently and at a lower cost, or if not at a lower cost, with greater benefit. I don't have any data on any of this, but yeah.
One of my colleagues, Stacy Fisher, that you know, has been doing work with promotores, and I think that can be a great model. So promotores for patients who have cancer, and she talks about how if she were to go into, a household and try to talk to a patient and their family, she'd get the stiff arm. But, if a promotora goes in, they're sort of like brought right into the fold and can have these conversations. So I think that could really help from a cultural perspective, from a linguistic perspective, and it is less expensive.
we'll take one more. Go ahead, Pat.
I wanted to thank everyone as well, and I agree with what's been said. In terms of the cost, the other thing that I would add in terms of the conversation is really the need to identify and ensure that the family who's not been part of the discussion is aware so that there's no conflict when emergency strikes. And I think the second piece is what Diane raised earlier, which is the care planning that's required when a POLST is done to ensure that there's an adequate plan, if comfort measures only, depending on the site, whether it's at home, whether it's a nursing home, whether it's assisted living. So that was my comment. I did have a question for you, Alan, about reciprocity of advanced directives and POLST forms. I liked your recommendation, but seeing some of the political constraints of different legislation, it's something to strive for, but when I see that reciprocity for advanced directives has not been affected in our country since Patient Self-Determination Act, it makes it hard for me to think that we'll get a uniform approach to the POLST. So just a question about that for both advanced directives and
When you
POLST.
say reciprocity, you
That
mean
means
enforceability of a
across-
document executed in one state and another state?
Exactly, which is, there's a lot of variation in terms of any of the legislation
Yeah.
that's been passed. And so as people, they don't stay in their one little area, there needs to be a
Well,
reciprocity.
they damn well better.
Well,
You know,
they
that's
don't.
the problem. You would think that this would be something easy to solve by having a legislative provision that all states would adopt. And indeed, the Uniform Healthcare Decisions Act has such a provision. I don't remember what it is. And if every state would adopt it, fine. They won't do it. We know that because they haven't, and I don't think they will. There's any indication they will. So this again is something possibly for Medicare to take on if Medicare is going to get involved in doing this. I mean, that's really going to have to be the sources. We know that almost, well, that's the big payer here. You know, without Medicare pushing something, the likelihood of its happening is not great. Oh, yeah, well, Medicare can do that because they can say any facility that accepts Medicare payment must do it for all patients, which they've done, for example, for Patient Self-Determination Act doesn't apply just to Medicare patients.
There is a federal bill pending that would do that. It's not going to pass right now, but it's at least out there.
Well, you can say that about most federal bills.
Well, this has been a wonderful discussion. I think we owe a great debt to each of you for bringing these issues forward. I do want to end with an obvious comment, which is a follow-up to the point that Bernie made, which is that at the end of the day, these discussions all require time. Time is the uncompensated component of this. The quality of those interactions are extraordinarily important. I think there's a dissonance that exists, unfortunately, between the providers, their experience, knowledge, ability to do this, and their willingness to spend the time to do it. And each of us who've been on different sides of the medical care system recognize that. If we don't get that right, allow there to be time and define who's going to be the individual having this extraordinary discussion, it will fail. And then the option that Diane spoke to is going to be the unfortunate default, and that is a sad testament. So I hope in our continued deliberations we'll benefit from this dialogue, and we'll have an opportunity to formulate how this comes into the equation. But if we can't get time to allow the discussions to take place in a sincere and honest way, we won't accomplish the goal that we've really set out to do. So with that, we're going to take a 10-minute break. We're going to come back and then have public comments, and then we'll end this morning's session. So 10 minutes alone, and there we go. Thank you all again.